So, hello and good day to everyone. It's so nice for you all to join us. Welcoming 2026. This is our first round, and it's great to have some familiar faces back in this webinar. Thank you so much, Prof. Kato, for always supporting us. Maybe you would like to say something as an opening for this year, for the WIN?
Happy New Year to you all. I think maybe that this year is maybe you have a lot of the things it can be true, I think, for the best.
Okay,
and
thank you.
today's webinar is very, very nice to hear. One is Enkhbayar, the old friend. And also I want to hear about how develop of the Mongolian Neurosurgical Society now. And also, of course, the Sabino AVM talks.
Thank you. Thank you very much.
Thank you.
So today, thank you very much, Prof. Kato. So today we will be, Abhidha will be sharing the session. So Prof. Abhidha, we all know her very well. She's part of this WIN ACNS team, and she's always been faithfully assisting me every month. I'm so glad to have her. And as usual, our moderators or discussions, as usual, Prof. Alexandra, thank you so much. You've helped us out every time you're free. I know we take up your Sundays, but thank you so much for being with us. And we are so grateful to have Prof. Virendra Dio Sinha to join us this time around. Thank you, Prof. Virendra, for joining us. We are so happy you could make time for us this time. And we have some interesting talks today. Prof. Enkhbayar, again, thank you so much for joining us. It's always very nice to get someone from, a place where we all don't really commonly get to visit, but, for us to get a eye into what's happening in Mongolia, that's really great. Thank you so much for joining us. Prof. Thank you so much for joining us, Prof. Sabino Luzi. I see you'll be presenting something interesting for us today. And to end it all, every session we have someone who is introduced from WIN in a different country, and this time we'll have someone from the UAE to be introduced. So without further ado, I shall now call upon our chair for this session, Professor Abhidha Shah, to start off and to introduce our first speaker, Prof. Enkhbayar. Thank you, Abhi.
Thank you, Sharon. And let's kick off 2026 with this first webinar with the last chapter of neurosurgery, that is arteriovenous malformations. So you started with the most complex, and let's see, we have a good year ahead. So I will be presenting my learning point at the end. So first, I'd like to invite Professor Enkhbayar for her talk. She's the president of the Mongolian Society of Neurosurgery. And welcome, and we'd like to hear from you.
Okay, thank you.
Beg your pardon, can you see the screen share?
Yes.
Yes, we can see.
Hello. My name is Enkhbayar. I am the president of Mongolian Neurosurgical Society. Today, my presentation is about global neurosurgery in Mongolia. In short, I would like to give you an idea of how neurosurgery is developing and being practiced in Mongolia. Mongolia is a large, landlocked country between Russia and China, with a land area of 1.6 million square kilometer and the population about 3.5 million. Its vast territory and sparse population create unique challenges for healthcare delivery and including neurosurgery. In 1954, the first general surgery hospital was established. In 1966, the first brain tumor surgery was successfully performed on a 12-year-old girl. That same year marks the official foundation of the Mongolian Neurosurgical Service. This year, 2026, we celebrate the 6th anniversary of neurosurgery in Mongolia. First advisory specialist from USSR. Between 1966 and 1971, the foundation of Mongolian neurosurgery was established. In 1966, the first brain surgery. In December 1970, Dr. Rachkov from the USSR was invited to train specialists. And first independent neurosurgical department was opened with 24 beds and 4 neurosurgeons, including Dr. Rachkov from Russia and Dr. Khairullah. Our specialists worked hard with all their hearts. Currently, Mongolia has 42 neurosurgeons, 20 neurotraumatologists, and orthopedists, 3 neuroradiologists, and 15 neuronurses. Despite this, the workforce is still insufficient to meet nationwide demand. In terms of diagnostic infrastructure, there are 22 MRI scanners, with only 3 in the countryside, and 46 CT scanners. This is our Mongolian neurosurgical teams in these pictures. So Mongolia has shown a steady growth in the recent years. The government hospitals with increasing urbanization, both state and private hospitals are being established across the country, improving access to neurosurgical care. You can see this slide. Here's our departments of the neurosurgery in Mongolia. The first central hospital is Mongolia's first state-run hospital with 7 neurosurgeons in the Department of Neurosurgery. It is located in the center of Ulaanbaatar city. Second central hospital, also now established the Department of Neurosurgery with 4 neurosurgeons. This hospital especially receives patients from eastern province of Mongolia. Third central hospital, named Shastin, this is the biggest hospital of neurosurgery. Now is working 40 neurosurgeons in the Department of Neurosurgery. National Cancer Center, Oslo, newly established Department of Neurosurgery. This neurosurgical department of the National Cancer Center is a newly established unit equipped with the most comprehensive world-class technology currently available in Mongolia. Now is working 3 neurosurgeons. Also, National Trauma and Orthopedic Center. There is a working neurotraumatology 20, including 2 female neurosurgeons and 5 orthopedists. This is Mongol Japan Hospital. Department of Neurosurgery was established in this hospital 2019, especially on the hospital that does epilepsy surgery, resection of the epileptic focus, cortical resection, important step toward functional neurosurgery development. Can you see the Professor Kawase, Kinsuke Kawai? I remember Professor Kato. We met here this time and we were talking about the establishment of Mongol Japan Hospital in the Mongol Japan Hospital to establish Department of Neurosurgery, especially for epilepsy surgery. Scope of neurosurgery in Mongolia: brain tumor surgery, head trauma, intracranial hematomas, vascular neurosurgery, spine, pediatric, the microscope, neuronavigation system, neuromonitoring, neuroscope. That's all equipments we are using now. Training pathway of Mongolian neurosurgeons. Official pathway to become neurosurgeon in Mongolia: graduation from medical school, 2 years general surgery residency, 1 year neurosurgery fellowship. This is the nationally recognized preparation system. Internationally skill development, now very much for education. You can see this country to contribute and support to educate Mongolian young neurosurgeons. We are very much glad to them and appreciate our professors from these countries. Mongolian Neurosurgery maintains strong collaboration with international organizations such as the WFNS, ACNS, Federation International Education of Neurological Surgeons, China ENE, WCNS, and regular international courses, fellowships, and visiting professors. ACNS Professor Tetsuo Kano and Yoko Kato from Fujita Health University in Nagoya, Japan, provided significant support and assistance to our department. Still now, we are very much appreciate to Professor Kato, Professor Tetsuo Kano. They are too much contribute in Mongolian neurosurgery or all neurosurgeons. We are 2007, Mongolian Neurosurgical Society joined WFNS on the AVMs Third Congress in Nagoya, Japan. Also, we organized a WFNS education course 2011. It was very nice course and developed very much to educate Mongolian neurosurgeons and also Mongolian neurologists or all Mongolian doctors. Also, from Federation of International Education of Neurological Surgeons, they are all send us very famous doctors, professors. For example, Tamir Banerjee. We are working together and doing many nice surgeries. Can you see the Dr. Professor Mirwam Bagang? He's very famous professor and chairman of the ACNS. Also, he visited in Mongolia and giving education to young neurosurgeons in Mongolia. And Professor Albert Sofianov, you know, he is famous professor in Russia. There are many young neurosurgeons educated under his supervision in Russia. Women in neurosurgery, we have become big team in women neurosurgery in ACNS or WFNS. We have getting big family of women neurosurgery. Also in Taiwan, some neurosurgeons educating very much. Indonesia, under the supervisor Professor Eva and his support, Mongolian neurosurgeons and nurses were training very well. They are still working in Mongolian neurosurgical cells given to neurosurgical patients. Also, biggest contribution from China under supervisor Professor Lin Fing. We also very much appreciate Professor Lin Fing to support giving much education to Mongolian neurosurgeons. Just continuing China in education, international doctors participating too much. Also China. Today is many doctors studying in this famous seminar. This is Nagoya, organized under the supervisor Professor Yoka Kato. Wonderful training in a vascular section. Thank you very much, Professor Yoka Kato, giving us great opportunity to study in your neurosurgical theater. Mongolian Neurosurgical Society and ACNS Training Center established 2 years ago in the Cancer Center. There is the national microscope from Professor Yoka Kato. We still using the young neurosurgeons to train. It's very important. Improving the skills and practicing. Can you see this? Professor Sofianov also visiting this training course 2 years ago. Last December, we are participating Global Neurosurgery 2025. It was a very nice congress, and we are watching our WFNS officers. It was very nice, wonderful course. Great challenges. Vast territory and long travel distances, limited number of neurosurgeons, insufficient equipment and technology, limited local training opportunities, available of limited procedures, school-based surgery, endoscopic neurosurgery, functional neurosurgery, radiosurgery, advanced neuronavigation-based procedures. future goals: improve neurosurgical training systems, increase neurosurgeon and nurse workforce, introduce advanced neurosurgical technologies, reduce the need for patients to seek treatment abroad. Vision for the future: build internationally standardized neurosurgical care, strengthen global collaboration, make advanced neurosurgery accessible within Mongolia. Thank you for your attention.
Thank you, Professor Enkhbayar, for giving your experience in Mongolia and the status of neurosurgery in Mongolia. First, I'd like to invite Professor Kato for a few comments before I call our discussions.
Very much, Enkhbayar. Your voice is a little bit small, so sometimes I cannot catch.
Sorry.
What you say, but I think. But you said that day by day, your society is improved. I think maybe such kind of the training, the YNS that we can accept. Yes, you can send us, and sometimes we can visit your place and demonstrate the surgery or hands-on workshop together, or educational course in near future, I think. Thank you very much. I'm so happy to see your development.
Thank you very much.
Thank you.
Professor Alexander, would you like to say something?
Yes, Professor Enkhbayar, thank you very much for such a comprehensive talk. You depicted us almost all the system of neurosurgical care. Of course, I see you have a problem like any neurosurgical service in any countries. And first of all, it's training. 3 years, actually 1 year, it's not enough, of course. I understand it's a post-Soviet, like a tradition. We have changed it recently. We changed it for 6 years, and that's really good. And I advise you to try to change the system and to, of course, to make the education longer. Of course, the big problem of your country is a big territory and not enough neurosurgeon. I'd like to ask you about the system of management of cerebrospinal trauma in your country, because it's a really problem, big distances. It means you require transportation for the big distances from the rural places, from remote places. Do you have local regional centers for trauma management, or you transport patient to the center? And what kind of transportation do you have? Do you have air mobile transportation or only ground transportation? I think it's also very, very important.
All right. If I'm not excuse me, if I'm not mistaken, you're from Ukraine, right?
Yes.
You know everything about Mongolia. That's right. You're right. Mongolia is a very big country, and also we have only one traumatic center in capital of Mongolia. So that's the issue. We don't have any regional or local traumatic centers in our provinces. So the problem is, just you said it, like the patient who has some injury in head, they go to the capital city by themselves, not by something like government provided airplane. We don't have anything like that. Patients take care of themselves. That's right.
Okay.
We only have one center in Mongolia. It's the biggest one. We do a lot of surgeries there, but as you said, we have a problem in our provinces.
Yes, of course. I think the next step is organization of air mobile service for patient transportation from all over the country. Okay, thank you very much. Good luck, and yes.
And last 3 years, since we are using the airplane from countryside to trauma center, the spine and the brain trauma patients. But it's not popular. It's limited.
She's trying to say we are working on it. We are training. It's just a training. It's about to beginning, but not working right now. We are about to do this job as soon as possible. So that was training.
Great. Okay. Thank you. Thank you.
Professor Sinha?
Yes. First, I want to compliment Dr. Enkhbayar for excellent presentation. And we need such presentation from all low-income countries or developing countries. So one knows what are their problems. So we all understand there is a disparity between the medical care across the world. And this disparity must be bridged by a number of tricks or systems, like giving the training, giving the instruments to these countries, to the webinars, and giving the education activities. Sharing the education activity is very important. So in my personal experience, what I know that Professor Kano and Kato has proved them. So they were inviting the fellows from the low-income countries. Even I went there and I learned the spinal fixation in Japan. And I did first time in my center. So we must do the shift or sharing of the education activity. Surgeons should go from this higher center to lower center, so the fellows can come to higher center for learning. And this is very important for solving or improving the neurosurgical skills. And recently, just I want to share that AACNS Asian Australasian Society, we just form a young forum to support the young neurosurgeon. And anybody wants to come to India for 1 or 2 months, we will provide total hospitality. We will take care of that. Only he has to provide the airfare. So we are if anybody comes from Mongolia, we will welcome to them. So I think this will be very good initiate from us, from AACNS, and definitely we must go for all this sharing. Thank you very much.
Thank you very much, Professor Sinha.
Thank you. Thank you, Dr. Sinha. We also have Professor Goel with us. Would you like to say something, sir?
Yeah, first of all, it was my great pleasure to see the glimpse of Mongolia. I have never been to that beautiful country. I saw the hospitals, I saw the facilities, I saw the neurosurgeons, and I saw the equipment. I think we should not be, Mongolia has everything to be proud of, everything to be very happy about. And there is no question the number of patients that you are seeing, if number of neurosurgeons is less, you are seeing more patients. So that is the advantage. And that advantage, you must, exploit that advantage rather than getting disturbed or getting underwhelmed by this situation. So first of all, I am happy to see the country. Second thing is I am happy to see the hospital and equipment in the various hospitals. And third is the number of patients that you are treating is quite good. So I am not having any kind of doubt that the neurosurgeons from Mongolia will grow and grow further to very high levels. As far as the training is concerned, this will depend on each individual resident and young neurosurgeon, how he wants to get trained, where he wants to get trained. Wherever there is a will, there is a way. And with the WFNS Foundation, with the WFNS education, there are so many committees and so many establishments which are ready to help. So what I have to say is, be proud of what you have and look for the moon, and you will get it. So that is my message to all young and senior neurosurgeons of Mongolia. My best wishes to you.
Thank you very much.
Thank you, sir. And Professor Enkhbayar, we would also be happy to have your residents and fellows for training with us whenever you want. So do let us know.
Yes.
Does anyone else have any comments or questions?
I think I want to tell about the neurotrauma patient. The pre-hospital care is very, very important. So even you have a sophisticated hospital and everything, but pre-hospital care is very important. And in countries like us, the trauma is rising. So in our setup, we improve the pre-hospital care. I think you must work for the improving of the pre-hospital care. It's very important for countries like us.
Yes,
Okay,
Professor.
thank you very much for your statement.
Yeah.
I think I have to agree with Prof. Sinha. Maybe Prof. Enkhbayar, one of the things you can do is like Prof. Alexander is he highlighted cerebral spinal traumas. I think one thing you all can do is maybe like your young residents or your young neurosurgeons can go to the provinces and actually set up like neurotrauma centers there
Yes.
to actually sort of train, but with the basic equipment. But at least the trauma cases can get the initial good care, like an urgent decompression or an extradural, which can be evacuated and then subsequently transferred to a better center for further care. I think that would be helpful, because it's kind of sad to think that if you get an accident in the province, your chances are not good, and if you get an accident in it's kind of sad when you think of it. But I think that's a common thing, and accidents are getting more, especially in countries where we have a lot of motorbikes and bicycles. So I think this is something we have to be aware of. I think a lot of us live in these kind of countries, so we're quite aware of these problems.
Right.
Okay, so if we can move ahead now, I'd like to invite our next speaker, Professor Sabino Luzzi, who is the chairman of the Department of Neurosurgery in the University of Sagni at Sardinia, Italy. And he tells us that it's a very beautiful place, as I'm sure he will tell us now. Sabino, welcome.
Thank you. Thank you very much. Can you hear me?
Yes, I can hear.
Thank you. Thank you very much. I want to just say that it's a very honor and pleasure to be here. And thank you once again to Professor Cato. And congratulations for this beautiful family and beautiful mission that you have, because it's so inspiring to listening to, how to improve the neurosurgical care globally all over the world, and how to help other people, because neurosurgery is able to save life. We do every congress, we do sometimes, every kind of, but maybe this aspect, especially in the young people, is a bit underrated. Neurosurgery, it's a life-saving, branch of the medicine. So it's so inspiring and so beautiful to spread the whole concept of microneurosurgery, especially microneurosurgery, all over the world. So thank you very much once again for this kind invitation and for spreading neurosurgery, as I just told you. Can you see my screen?
Yes, we can see.
Yes,
Okay,
can see.
thank you very much. I just want to start my lecture here to introduce you my university. This is my institution, and I represent this institution, that is University of Sardinia, University of Sassari in Sardinia, Italy, and this is an overview of the main headquarters of the university. As Professor Abhidha Shah just told, I just want to introduce myself. Sardinia is a highland affiliated to Italy, and it is in Sassari, it is in the north of this highland. And this is the logo of my institution. This is my university. This is very old. It's about 500 years old university. And we have lots of facility here, especially for young people that are listening to us. And we have a dedicated Erasmus trainship program in Sardinia here for medical students and for residents. So I want to tell that we can serve as a training center also for Mongolian guys and Mongolian resident. Whenever you want, please contact me. And here, this is an overview of Sardinia. That is, this is an autonomic region. This is Sassari, and this is Alghero. This is an airport that is very close to Sassari, just 10 minutes, 15 minutes by car. And this is my new affiliation. I recently moved to this hospital just 1 year ago, and this level 1 hospital, level 1 trauma center, that is AU Sassari. And this is the catchment area of my hospital that serves basically most of the north and the center of the island, with 1 million and a bit more of 1 million of people about catchment area. And this is an overview of Sardinia, about the place, as Professor Abhidha Shah was telling us. This is basically a sea place, a vacation place where you can enjoy lots of tradition, lots of culture, folklore, and it's nice. And all of you are invited to come whenever you want. And this is just to show you that this is a magic place, and sometimes it's very difficult to go to work in the very early morning. I'm very happy to be here, and I never stop to say thank you to all of the people that gave me this beautiful opportunity. The topic for today is brain AVM surgery, strategies and technique. I want to humbly share with you some concept that I learned during my career. And this is a natural history. This is a slide showing a natural history in an overview of the brain AVMs. They have of known an hemorrhagic early risk of 2.4%, about 2.4%, overall mortality of 18%. And we have to take into account one of the most important aspects, that is the fact that the incomplete obliteration of this kind of AVM, or especially for middle size of huge AVM, increase the risk up to 2 times to 4 times the risk of mortality risk and deficits risk, up to 8 of 12% per year. And the mechanism based of his risk, increased risk in case of incomplete obliteration and exeresis of AVM, is an alterating hemodynamics with residual nidus instability. So it derives that the treatment of AVM is mandatory, especially for grade 1, 2, and 3 Spätzle-Martin. That is the classification that we commonly use in our routine surgical practice. About the treatment option of AVMs, microsurgical resection is the key to treat all the AVMs. That's the reason why it is very well highlighted. Apart from this, why this? Because microsurgical resection is the cure of AVM. It is the definitive cure of AVM in more than 95% of the cases. Apart from this, we have other more recent treatment options that are transarterial anterograde or transvenous retrograde catheter-based embolization, that in most of the cases is just an adjunct to the microsurgical resection, as I will show you some cases now. And then we have radiosurgery that has very limited role for AVM. Sometimes it could be, this kind of treatment can have a role, especially for high grade 5 AVMs or 4 AVMs. And now we are starting to talk about some experimental pharmacological therapies that are anti-angiogenetic factor. In most of the cases, we use combined treatment in terms of microsurgical resection, basically, and transarterial or transvenous catheter-based embolization, especially for Spätzle-Martin grade 3 AVMs. And this is an overview, especially for the young people that will attend this lecture about the decision making. I try to do my best to summarize the key factor based on the decision making of brain AVMs. The first is the angioarchitecture. For sure, we have to study in detail the angioarchitecture of AVM, because all AVMs are different. And now we have to move toward the grade of the AVM. The grade is very important because we know that there is a clear indication for grade AVM ranging from grade 1 to grade 3, and it is debated putative and theoretical indication for grade 4 AVM. There is, most of the cases, no indication for treatment in grade 5 AVM because of the greater mortality that is associated to this kind of AVM. Another important aspect is the presence of deep feeder that totally changed the strategy of the AVMs, as I will just show you. And then also the presence of the so-called high-risk feature for bleeding. Which are the high-risk feature for bleeding? When we see, and then we look at the angiogram and the digital subtraction angiography of this patient, we have to recognize if this patient has some flow-related of intranidal aneurysm, or especially, as we learned from Professor Yashagi directly, the stenosis of the straight sinus is another important red flag for this kind of AVM. Why? Because this is a hypertension of the system of the vein of Galen. And that AVM that represent the stenosis of the straight sinus are very close to rupture and very close to bleed. So these are these are the main high-risk features that I always take a look to any angiography when I plan the treatment of AVM. These are just some cases. This is the first case that I want to show, brain AVM. This is a left trigonal plexal AVM. These are very, very complex AVM. Why? Because the main vascular supply of this AVM comes from the choroid plexus, and especially lateral and medial posterior choroidal artery, especially lateral posterior choroidal artery. This is what we called in the recent classification, in the revision of the classification of Spencer and Marty coming from Lawton, is a medium deep AVM. And as we see here, the patient was very young, 43 years old male, progressive visual impairment because of the size of this AVM. What we see here, we have the huge nidus of AVM, and what I immediately realize is the fact that this AVM is a flow-related intranidal aneurysm. So that's the reason why this is very high risky feature that I see in the AVM. So the planning in this case is a preoperative embolization because of most of the deep feeders coming from the lateral posterior choroidal artery here, then followed by surgery. And usually the time frame between the last session of preoperative embolization and surgery is no more than 5 days or 6 days and maximum, because otherwise the nidus start to rearrange and to recruit other feeders, and the grade could be changed in a higher, time frame. After that, we have to do the planning was a super selective transarterial embolization of this AVM. And for sure, we have to navigate, left posterior cerebral artery and then left posterior choroidal artery, using in most of the cases Onyx 18 is now used in most of the cases because it is able to fill even the small vessel, because it's the low density onyx, as they call this kind of treatment option. And then we have posterior interhemispheric transpericolonial approach that was performed 7 days after the last embo session, and the patient was placed in modified Park-Banks position. This is just an overview. We did, 3-stage embolization of this kind of AVM. The first embolization session is reported on the left side of the screen, and this is the final third embolization session. As you see here, everything changed, and we were able to adopt what we call the downgrading, a functional downgrading of the AVM, and the calculated in terms of nidus and in terms of volume of the nidus obliteration rate was more than 50%. And what I want to stress is that in the strategy of the preoperative embolization of these grade 3 AVMs, we have the staged embolization targets. And these targets are totally different according to the fact that we talk about the first session and further sessions. Because in the first session, we have to aim at decrease the risk of, normal pressure perfusor breakthrough phenomenon in large volume AVMs. And in the further session, we have to eliminate the deep-seated, difficult to access part of the AVM. So we are totally different. So the first session is totally different from the second session and third session. That's the reason why we don't have to exaggerate. We don't have to perform an over-treatment of the further session. Why? Because in the further session, the staged embolization is targeted to eliminate the deep-seated feeders, and we can control some of this feature even during surgery. In this case, we use a modified Park-Bench position. As you see here, we have the opportunity to open a corridor. Why? Because we put the head at the 45 degrees, and in doing this, we open a corridor in between the falx, and we have the opportunity to open the falx, to cut the falx, and to dominate also the contralateral side. And this is very important also for the comfort of the surgeon during surgery, but the head should be placed at the 45 degrees because we can take the advantage from, what we call gravity-assisted retraction of the left occipital lobe. And that's the reason why in the OR I'm compulsive to find the perfection in terms of positioning of the patient, because for me this is one of the most important aspects, and this is the key to open the surgical corridor. And this is what we can realize if the patient is correctly positioned here, because we have the correct venous outflow from the head district. we performed the CSF withdrawal, and this is the cuneal vein here. And these are the main steps. I don't have time to show you the entire video, but these are the main steps of the posterior interhemispheric transpericuneal approach for this kind of AVM, where, you know, this is the post-op results, and this is the pre-op and post-op. All the nidus was eliminated, also thanks to the fact that the nidus was more firm and more compact after the three stages of embolization, as I just showed you. I had the privilege to publish some concept about the functional downgrading of AVM and the role of the combined treatment, especially in grade 3 AVMs, in several papers. And I want to also focus the key surgical steps of brain AVMs about surgery. When we take a look and we have to treat an AVMs, I always take care about three different kind of aspects. The first one is the perfect anatomical localization. The topographic localization of the AVM is very, very important. Like a tumor, we have to recognize the limits of the nidus of the AVM, and then the approach selection, and then the technique, but the technique is slightly different in a different kind of AVM. When we talk about the localization of AVM, I have never used the axial slide. I always use the coronal and sagittal. Why? Because they are very, very important to reconstruct in my mind the anatomy, the local anatomy, and coronal and sagittal as the most important, sequences that I use on MRI and digital subtraction angiography, also to spatially recognize and put my AVMs in terms of anatomy. This is another case, for example. Where is this AVMs? This is a 70-year-old female patient, otherwise else is suffering from seizure. This is post-central gyrus AVM, as you see here. AVM, why? Because we have a small bleeding here, and the small bleeding is, as we see here on the CT scan, it is not post-central. I want to come back here. Apparently, it's in the post-central, but when I perform here the MRI, I see that the omega region is just below this kind of spot. So it means that this is the pre-central gyrus AVM. So sometimes the CT scan on the axial slides can be misleading. That's the reason why I've never used the axial slide here. It's always better to use the coronal and the sagittal here, but on the axial slide AVM, we see where is this kind of bleeding. And also this kind of bleeding was apparently silent here, but obviously we moved forward to recognize and we did digital subsection angiography, and obviously we found here this small, very small nidus of AVM in the pre-central gyrus. Very complex case to treat because it is a small AVM, but in a very super eloquent area here. And always, when we have to recognize where is this nidus, I always want to see the AP angiography. Why? Because a nidus of this small AVM is exactly at the level of what they call the angiographic Sylvian point here. And the angiographic Sylvian point is in the turning point, that it is in the transition between M2 and M3 segment at the end of the insula, at the level of the superior limiting sulcus of the insula. And the small nidus is just a little bit higher to that point, as we see here. And on the coronal section, and on the lateral view, this AVM is exactly at the level of the premotor area. So this information are super important for me, because I have to plan my surgery. I have to recognize where to do my craniotomy in order to beautifully expose not only the AVM, not only the vascular arterial feeders, but also the venous outflow of this AVM, that, as you see here, was transmedullary toward the superior sagittal sinus. When we talk about the coronal aspect in terms of localization of AVM, we have to go back to the phylogenesis of the telencephalum here. It is very, very, very important, and we have to recognition of this, the subpallium, paleopallium, archipallium, and neopallium here, and in the phylogenetic here evolution, we have some specific subcortical topographic region where we must recognize and we must put and localize from the surgical and topographical standpoint the nidus of our deep-seated AVMs. And also, we have to come back to the proto-mammalian telencephalum here, where we see three kind of different, we are talking about, you know, the phylogenetic evolution, very, you know, million of years ago. We have the primitive fissura hippocampalis here, that is, you know, the precursor of the so-called cingulate gyrus. And then we have a fissura marginalis, that is the precursor of Sylvian fissure. And then we have the renal sulcus, and that is, you know, here the fissura renalis, that is, you know, the primitive ancestral fissure of the so-called collateral sulcus here. This is very important. Why? Because still today we have this kind of fissure, the cingulate sulcus, the circular sulcus of the insula here, and the collateral sulcus. And when we talk about this kind of sulci, we have a boundary here, and we trace a line, and this boundary is totally different because, as you see, the neocortex and the new brain, the telencephalus, is immediately outside of this border, and the old brain is immediately inner to this order, to this phylogenetic boundary. And this is very important because this is very important also for AVMs. I will show you why, especially in deep-seated AVMs. Here we can have, especially at the level of the pallia, subpallia, some, you know, distinction. As you see here, this is an overview in terms of genes. And this is a gene mapping technique. We have a totally distinct, you know, zone in terms of a pallial zone. And we have the pallium, subpallium boundaries here. And as you see, some genes are presented at the level of the subpallium, and other genes are presented at the level of the pallium here. And this is the evolution. In the evolution, this is from Puelles, we have some striatal pallium, pallidal pallium, diagonal pallium, and preotic area in terms of pallium. And when we take a look on the coronal angiography and the coronal, you know, angio MRI, as we see here, we can recognize that the artery, especially the lenticulostriate artery, immediately follow this kind of structure. And we have that, you know, the lenticulostriate artery divide the striatal, pallidal, diagonal, and preotic area here. And this is exactly what we see, and we want to see on the digital subtraction angiography of the patient harboring the AVM, because there is an implication, especially for deep-seated AVM, of this kind of structure. When we take a look to the 7 Tesla MRI, we can recognize beautifully at high definition this kind of subsegmental differentiation of the deep-seated part of the subpallium. And here we can have the striatum, pallidal, diagonal, and preotic area here. And this is this kind of organization has some consequences from the phylogenetic point, even from AVM. Why? Because in the AVM, in the normal brain anatomy, we have the striatal arteries that come in terms of ventriculopetal fibers, comes and make it and became closer to the ventricle. At the level of the ventricle, we have a connection with some ventriculofugal fibers here that goes from the ventricle toward the cortex. And in the most of the cases, we have a boundary here that was described for the first time in the 1994 by Professor Yashagi and Valavanis here. And in this, you know, border, in this, you know, in between, it is a neocortical, intratelencephalic, and pallial, subpallial boundary. We have the transition watershed zone between the ventriculofugal and ventriculopallidal fibers. And this is the ventriculofugal and ventriculopetal and ventriculofugal fibers. And that's the reason why in most of the cases the neocortex and the neopallium AVM are recruiting some deep feeders from deep-seated lenticulostriate arteries here. And this is a beautiful, beautiful picture coming from the book from Professor Yashagi that show how this kind of AVMs, regardless by the size and the volume, are totally different, because some AVMs are totally external to this kind of, you know, phylogenetic boundary of intracortical boundary. And for this kind of AVM, we just can opt for surgery. We don't need any kind of embolization. Why? Because embolization cannot change the surgical strategy, because we don't have deep feeders from this AVM. Totally different is the condition where The AVM is funnel shaped, and the fundus of the AVM reaches the area very close to the ventricle where we have the transition point in between the pallial subpallial border and intra-telencephalic border here. And for sure, we can have some recruitment of the ventriculofugal and ventriculopetal fibers here. And for this AVM, these AVM are more challenging from the surgical standpoint, from the surgical point of view. And this is another classification that I usually I use in my mind, that I focus in my mind, that is several times better, in my humble opinion, that simple volumetric and functional classification coming from Spetzler and Martin. This is a pure neopallial AVM. As you can see here, we have a bit far from the ventricle here, and we have a lesser risk, you know, from to have some feeders for this kind of AVM. And then we have some archipallial, paleopallial, subpallial AVM with nidus totally localized in totally different zone, and this is very difficult for the approach. And as you can see here, these are two different forms of neopallial AVM. In the first neopallial AVM, we have some choroidal feeders, like the first cases that I just showed you, coming from the plexal, you know, from the choroid plexus here. This is a cortical neopallial AVM. This is from several standpoints huge. This is even more huge than the first case, but in this case we are far from the ventricles, and in this case, for sure, on digital subtraction angiography, we have we will not find any choroidal feeders from this kind of AVM. So this is also sulcal AVM and gyral AVM, because this AVM is inside the brain, and this is totally different story. I told you about the architecture of AVM. We can have some cortical AVM or subcortical AVM. This is totally different because, you know, in cortical AVM, the first aspect that we can see is the venous outflow from the AVM, and then the nidus is hidden usually from the venous outflow. And we have to skeletonize the vein for as the first step of surgery to immediately reach, from the technical point of view, the feeders of the AVM that usually come from neighboring tissue or also deep feeders. In the subcortical AVM, we don't see anything. We immediately can recognize we should just follow the arterial feeders at the depth of the sulcus. We have to skeletonize it. We have a higher likelihood to easily skeletonize the deep arterial feeders, go subcortical, and immediately have the access to the nidus of the AVM. About the sagittal projection here, we have the primordial neopallial gyral units of the AVM, according to which we can perfectly recognize where the AVM is in terms of gyral, in terms of gyral anatomy. And this is a beautiful picture coming from the past, coming from the Yakovlev 1968. And as we can see here, we have some epistriatal and epiapocampal zone. In most of the cases, if the AVM is in the most anterior half and the anterior half in the so-called epistriatal zone, this AVM will have some arterial feeders coming from lenticulostriate arteries here. And in the epiapocampal AVM, in most of the cases, if we refer to the gyral unit ranging from here, from 9 to 15, we can have some epiapocampal striata, epiapocampal vascular supply, and this epiapocampal vascular supply comes from usually choroidal arteries rather than lenticulostriate arteries. This is totally different concept, even that we have to take in mind, because it is totally different in terms of planning of surgery, in terms of surgical strategies, in terms of approach, in terms of skeletonization of the nidus and everything. And also in terms of risk stratification, because for sure there is stratification for the diencephalic subpallial AVM, getting the vascular supply coming from the striatal lenticulostriate, and medial and lateral lenticulostriate are more challenging lesion in most of the cases. And this is an overview of epistriatal AVMs and epiapocampal AVM. This is totally different. In the first, we can see the super selective catheter-based embolization, super selective catheter-based injection of the striatal system here. And here, this is a super selective of the inferior part of the slide of the lateral posterior choroidal artery. As you can see, it's totally different. This is what we have to recognize before surgery when I want to plan the surgery for AVM. About approach selection, AVM are no different from tumors, and Professor Yashargil already described the beauty of the transsulcal transcisternal approach to reach this deep-seated lesion here, and we can have the opportunity to recognize, to reach every part of the brain, even the so-called deep-seated AVM, and all of them can be treated by surgery. And in terms of technique, everybody knows very well the basic technique where we have to follow some dissection planes. The first plane is the subarachnoid dissection, and then we move forward to the PL dissection, parenchymal dissection, and at the end we can reach the deepest part of the nidus of the AVM, and we move toward the ependymal deep-seated dissection here. This is another case that the AVM, and the main concept is not a matter of volume of AVM, it's a matter of quality of AVM, it's a matter of topographic organization of the AVM, a topographic localization of the AVM. This is a frontal type 3 AVM, so-called medium eloquent. As you can see here, same strategy, grade 3 AVM. This is very huge, giant AVM, and the planning was the same as the first case that I showed you. Planning, preoperative embolization, followed by surgery. In this case, we opted toward the selective transarterial approach with Onyx 18, 2 stages, and surgery was performed, as I told you, within a week after the embolization, for the reason that I already explained it to you. And surgery here was performed on 5 days after the last embol. This is the outcome of the embolization here. This is the outcome of the second embolization, and the calculated obliteration rate was very close to 50%. And this is not the same case, but this is what we see every day, and this is the complex of the nidus, and this is for sure cortical AVM, cortical subcortical AVM, where one of the most important parts is to recognize the venous outflow, to skeletonize the vein, and then to skeletonize the artery, and then the PL and the ependymal dissection, as I just showed you. This is the pre-op and post-op after the last, you know, 1 month after surgery. And as you see here, the final surgical outcome is totally regardless by the volume of the nidus here. A few words and then I will conclude. I will move toward the conclusion. Some consideration about grade 5 AVM. Grade 5 AVM are no flight zone for surgery. This is a recent case that we managed in our department. Very young years old, 27 years old female, visual impaired, otherwise healthy. And as you saw here, and as you see here, large AVM here. This is grade 5 AVM with huge intra-nidus thrombosed aneurysmal flow-related aneurysm that with any probability was the reason of the worsening of the visual field, as we see here. And this is the MRI, and this AVM was very deep-seated, eloquent, and it's as you see here, this AVM is located at the level of what we call hippocampal zone, and for sure the vascularization, the main vascular supplies of this AVM come from the posterior choroidal artery and the lateral posterior choroidal artery. So it is totally different story compared to the AVM coming, the AVM that I just showed you. And this is the digital subtraction angiography that confirm, as you see here, the you know, 3 main vectors coming from the posterior cerebral artery and also from the posterior choroidal artery, and here huge volume, and we decided don't touch this patient, that sometimes this patient can be candidate for radiosurgery. In conclusion, because I don't have time, brain AVM, and what about the role of microneurosurgery? The role of microneurosurgery is critical for all AVM. AVM represent all microneurosurgery still today represent the definitive cure for AVM. It allows for an immediate elimination of hemorrhagic risk, especially for young patients, and it allows also for a precise preservation of neural and vascular structure. And because of this, microneurosurgery is still today the cornerstone of also the multidisciplinary AVM management. Thank you so much for your attention, and once again for this beautiful invitation, for this kind invitation.
Thank you, Sabino. It was a very fascinating talk, mixture of embryology with AVMs and their genesis. Very, very nice talk, and nice to see your experience. I'd like to invite Professor Sinha for his comments.
Yes, thanks to Dr. Sabino for showing the excellent cases, sharing the excellent cases of electrocardia and multiple embolization in AVM, which we don't see usually, but it is definitely helps this AVM. AVM definitely need very alternative techniques like endovascular, RSR and all. And sometimes we need advanced tool for this intraoperative angiography. May I know how many cases you use intraoperative angiography in your cases?
No, we don't have, unfortunately, intraoperative angiography. Now, within this week, they will start to build a new angio suite that they call hybrid angio suite, and I don't have experience about the use of intraoperative angiography because I work in 3 hospitals where they didn't have. Now they're starting to implement this kind of hybrid room in Italy, and to the best of my knowledge, there are just 3 or 4 centers, but my center doesn't have still the intraoperative angiography. Let's see, maybe in the future it could be of great help, because for sure you can have the opportunity to have an immediately feedback about what you did in the OR, and if you were able to totally eliminate the nidus of the AVM.
Yeah, definitely. And may I know how you proceed for watch the recurrence of the AVM after the surgery? How you watch these cases? How you monitor these cases?
Usually, as in the first slide, the second slide of my presentation, I showed you that this is one of the most complex aspects to deal with. Why? Because it's not like the tumor, you know. If you have a remnant in a tumor, you can perform different kind of treatment. You can perform chemotherapy or radiotherapy, whatever you want, and you decrease the risk of tumor growth. For AVM, it has been recognized and it has been reported in the literature that if you don't treat totally the AVM, the risk of bleeding can increase up to 10%. So it's very, very, very important. So apart from those cases where the remnant of the nidus is super, very small, I will put the patient back on the table and I try to do my best to eliminate totally the nidus of the AVM. But for sure, this kind of decision are very delicate, and we usually tend to have this kind of decision also in conjunction with our endo guys. Because sometimes if you are very lucky and your remnant is very close to the small feeders, they go there and they try to occlude and to do their best to occlude the kind of remnant. But the main problem in terms of AVM is the fact that, as I always tell to my residents, AVM is not a stone. AVM is not a static lesion. AVM is a dynamic lesion. That's the reason why you have to perform the surgery a few days after embolization, because there are some, mechanisms related especially to angiofactors, like vascular endothelial growth factor, that promote the growth of the AVM and especially the rearrangement of the nidus. This is what we have to take into account.
Okay, thank you very much.
Thank you.
Professor Alexander?
Yeah, thank you, Abhidha. Professor Lucio, thank you very much for great talk. Really very detailed, very profound, and very circumstantial talk. Thank you.
Thank you.
It's nothing to discuss, of course. I absolutely agree that the team approach is very important for management of AVMs, especially complex AVMs. But my question is, how do you see, or how do you recommend the inter-institutional organization of interinstitutional organization of cooperation between endovascular, and radio surgeons? Who is the main coordinator? How do you see them like together or separated inside of the institution? And actually, who is playing the first violin in this team?
Sure.
What is your option?
I'm trying to do my best. To be honest, I just arrived in my new hospital and I became the chief judge 1 year ago. So that's the reason why I'm trying to do my best now to implement. And what I did for tumor cases is to implement a tumor board. And in the tumor board, we meet every week to discuss about, the indication for surgery and how to manage that kind of tumor. And we tend to meet each other every week with a constant appointment, even when we don't have cases to discuss, because we can reserve that time also for the follow-up of the patient, because this aspect is sometimes, underrated. We have to follow our patient. We have to review and critically appraise what we did in that patient. And this is what I want exactly established for neurovascular cases. So my opinion is the fact that the best way to treat this patient is to establish a multidisciplinary team, a neurovascular team, like I did in the tumor board, because, I don't know why, but for tumor, this kind of concept is more common. For neurovascular cases, because of unfortunately, we are assisting to the shrinking of the case volume, and we know very well. And in most of the cases, we are confidentially, I laugh when I say that we are under attack and as a neurosurgeon, because, sometimes, but it is totally wrong to fight against the endovascular guys, because, now we should cooperate each other. We should have to have a seat not only with them, but also with the radiosurgery guys, because radiosurgery for sure has some limitation. It is not an option for most of the tumors, we know very well. But in some cases, like in cases that I showed you, and now they hospitalized another grade 5 AVMs yesterday afternoon in my department, but I was unfortunate because I don't have the picture to show it, but I managed in 2 years, just 1 year, I had already 2 cases of grade 5, pure grade 5 AVM. And grade 5 AVM, you don't have to touch the patient for sure for the surgical point of view. This is my humble point of view. But there is some space for radiosurgery, they told me. So that's the reason why we have to involve the colleague. We have to have a seat. We have to discuss the cases every week. Also to, follow up the aneurysm, AVM, cavernoma, everything.
Yes, thank you. I agree with you that we must meet to see each one together, not to try to make a decision by someone separately, but only in team. I absolutely agree with you. Thank you.
Thank you.
Thank you. Professor Fawad, are you there? Would you like
please unmute.
Unmute yourself, please.
Okay, Salam alaikum. Thank you very much. Thank you. It's great presentation, Professor Lozino, and also it's very nice to see Enkhbayar from Mongolia, and excellent presentation. And I like to say that your situation and experience and equipment is better than Afghanistan. Congratulations. Thank you very much.
Thank you very much.
And I would like to have collaboration with Mongolian Neurosurgical Society for doing some experience exchange and some cooperation as well. Inshallah.
Okay, thank you.
Okay, thank you. Arigato.
Does anyone else have any questions or comments from the
Dr.
panel?
Abhidha, Dr. Abhidha, can you share your experience? I know Dr. Atul was very fond of doing making the models of AVM, 3D models, and it shortened the time of surgery, mode of surgery, and everything benefits. So can you just share for a few lines, because I also did a few few models sometime, but I think you will be better to explain about this part.
I will do it now in my talk.
Okay.
Yeah.
So if we don't have any more questions, Prof. Kato, do you have any comments, or shall I just continue?
Yes, of course. Then please continue. Thank you very much, Lucy. Very nice talk. I think the teamwork for the treatment of the AVM is very important. So
thank you, Professor.
So radio surgeon is also the neurosurgeon in your country.
Yes. Usually, radio surgery in my country is performed by neurosurgeons.
Okay, so that's easy to discuss, I think. Thank you very much. Excellent.
Thank you.
Thank you very much, Prof. Sabino Luzi. That was, I think, really a very good talk. I'd like to now have the opportunity to introduce Prof. Abhidha Shah from ACNS Medical College and Chem Hospital, Mumbai. She will be presenting today brain arteriovenous malformation, when and how. Abhidha?
Okay, you can hear me now?
Yeah, we can hear you clearly.
Right? Yeah, so after this talk by Dr. Sabino, I'm going to just show a few technical aspects and decision-making in surgery for arteriovenous malformation. So the different aspects of management of arteriovenous malformations are either surgery, sometimes embolization, sometimes radiosurgery, and sometimes nothing. So that is the key of AVM treatment. You have to make a right decision on what kind of treatment has to be given to the patient. In our experience, we follow this philosophy. Either we operate the patient or we do not give any big treatment to the patient unless it's a very deep-seated or a small nidus which is amenable to radiosurgery. Embolization, we are not very fond of, and I will show you some slides as to why we do not prefer embolization. And this is the paper that Professor Goel wrote on the current status of surgery on arteriovenous malformation. And as he likes to say, surgery for large arteriovenous malformations is the last chapter in neurosurgery. So AVM surgery is like preparing for a war. You have to know how to get into the AVM, but you also have to know how to get out. So this image is from an Indian mythological story, as you must have all heard, the Mahabharata. This is about Abhimanyu, who is Arjun's son, who was listening to his father, talking when he was in his mother's womb. He listened to the part where he was taught how to enter this Chakravyu, but he fell asleep when his father was giving him a lecture on how to come out. So during the main war, he managed to get in, but he had a difficulty in coming out. So that is how it is with arteriovenous malformation surgery. You have to know how to get in and you have to know how to get out. There are some important learning points in AVM surgery. The first is the decision making, whether to treat the AVM or whether to leave it to its natural history. So if you're going to see an AVM like this, as Professor Sinha was just saying, this is a 3D model of an arteriovenous malformation. It is obvious that you cannot treat this patient by any means, nor by radiosurgery, nor by embolization, and definitely not by surgery. So this patient is better left alone to his natural history. So the indications of arteriovenous malformation are to be divided into two: the clinical indications and the surgical indications. So clinically, when will you go in for an arteriovenous malformation? When the patient has a risk of bleeding, when the patient has headache, severe dizziness, uncontrollable convulsions, altered sensorium, of course, when he presents with a bleed. So these are some of the clinical indicators of surgery. And when you look at a nidus, what do you look at the nidus? Look at the size of the nidus. You look at the number of major feeding arteries. You look at the venous drainage. You look at the presence of aneurysms. So this was our recent paper on the subject, where we analyzed our largest series of 89 patients having large cerebral arteriovenous malformations, where all of these malformations were more than 4 centimeters, either on the anterior or the lateral view of the angiogram. So this was our experience, and that is what I'm presenting. So when you decide on the surgical aspects of arteriovenous malformation, of course, we all know the Spechler-Martin grades and the modification of this grade, but we have to have an individual grading system for ourselves, because as we grow in our technical skills, the surgical grading will change for us. And this is Professor Goel's surgical grading, where he's divided the AVMs into 4 types: easy, difficult but safe, very difficult and risky but possible, and not safe or possible. This is a very dynamic classification in the sense that something that was difficult but safe for me maybe 7 years ago might be easy for me now. What was very difficult and risky but possible some years ago might be difficult but safe. And what was not safe or possible might actually be very difficult but still possible. So this is how the dynamics of the classification change. Of course, a lot of other anatomical and surgical factors come into play, but while performing AVM surgery, along with the anatomical factors of the AVM, along with the patient status, your own confidence and your own skill comes a lot into play. Now, looking at the location of the AVM, the next factor that helps in your decision-making is where is the AVM located. Now, to help find the location of the AVM, we have used various imaging modalities. So here you can see this is the CT angiographic view of the AVM. This is an MRI of the AVM. We also use DTI to figure out how the fiber tracks were involved, how they were displaced. And here you can see in this AVM, the AVM nidus is completely intraventricular and it is supplied only by the choroidal feeders. We also made 3D models for this AVM. This was our earlier prototype of the 3D model, and I will just show you how we have progressed in arteriovenous modeling, 3D model preparation in our experience. So this is the paper on the subject, and here you can see how the 3D model helps us. It will give you the exact location of the AVM. It is live size. It is in exactly the shape of the patient's skull. You can place it right next to the patient and plan your surgery. You can plan your craniotomy. You know exactly where the AVM lies. Of course, your anatomical landmarks on MRI are important, but this is just a physical expression of those landmarks. And once you have it in the eye, just like you see, the vision is the best way. When it is right in front of you, serves as a very good guiding tool while performing the surgery. So now you can see this is another AVM in the Sylvian fissure. And here you can see we prepared this model. And here you can see we color-coded this model to differentiate the arterial and the venous phases. And this helped us in locating the AVM. So this is how we use the 3D models during AVM surgery. We use it to plan the surgery. We keep it next to us during the surgery. We keep it to plan the craniotomy. So this is the anatomical location of the AVM. The second most important learning point or factor in AVM surgery is identifying the feeders. For this, you have to actually perform the DSA yourself, which we do, or you sit with the DSA and you play with it for hours together. You look at all the views, you identify all the vessels and figure out where the feeders are coming from, because that is how your planning will go. This is just a location of, if it is the frontal region AVM, these are the major feeders. If it is a temporal region AVM, this will be the major feeders that you will see coming from the AVM. This is just a small table that we have made. Now, this is another improvement we've made in the angiography, where we color code each vessel that is supplying the AVM with a different color and then fuse the images. So you see this huge AVM nidus that is being fed from the posterior cerebral artery, from the middle cerebral artery, as you can see here, and also some portion, this thing in the white, from the anterior cerebral artery. So you can see that this is a difficult AVM that is having feeders from all the 3 major arterial feeders in the brain. And this is an important fact that you should remember when planning your surgery. This AVM, which will have 3 feeders, is of course more complex than those having smaller feeders or lesser feeders. So next that comes into play is the eloquence of the AVM. When do you want to operate an AVM? Of course, this AVM has bled and we did operate this patient, but the location of the AVM is important. Sometimes the AVM is in the motor strip presenting only with convulsions. It might be better if you can just observe this AVM. So here you can see this is just premotor. We operated this patient. This is again another patient that had bled, and you can see the AVM right in front of the precentral sulcus, just abutting the sulcus. And here you can see the AVM, which I operated recently. This patient also did well. This is another AVM which had presented with an intraventricular bleed. Again, you can see that we fractionated the DSA, and you can see that 2 feeders are there, mainly from the PCA, as you can see in this angiographic run. And then you can see some supply coming in from the PCOM and also going into the AVM along with the choroidal vessels. So I operated this patient, and you can see that the AVM was removed. Now going to a higher grade AVM, as you develop in your technical expertise and your technical skills, you can see that you can surgically operate all of these higher grade tumors, higher grade AVMs with good results. So you can see another huge AVM in the region of the Sylvian fissure, fed mainly by the middle cerebral artery and going up and supplying and draining into the sagittal sinus by these huge veins. And you can see I operated this patient and removed the AVM, and the patient is doing very well now. I have just seen her recently, 15 days back on follow-up. Now, this is an embolized AVM. You can see someone had embolized this AVM outside, and obviously they were not able to completely embolize it, considering that it was a high flow AVM with multiple feeders. Now you can see the angiography of this patient. You can see the feeders from the posterior cerebral artery and the feeders from the middle cerebral artery. And here you can see some feeders from the anterior cerebral artery as well. So you can see the angiographic views. So you see there are 3 feeders, and you can see that this is a high flow AVM. I've operated this patient and he's doing well. The embolization actually does not help during the surgery. Actually, it makes for us the AVM a little bit, tougher to handle. It decreases the suppleness of the AVM. But of course, some people do prefer embolization, but as a general rule, we do not use embolization. This is an AVM that was being embolized by our radiology department. And you can see during the embolization, it bled. And this was the DSA just after half the embolization was done. This patient became unconscious and I had to actually operate in the night. And you can see this video. Actually, I'm not showing this video for the embolization, but I'm showing it for the most important learning point in this during surgery for arteriovenous malformation. And that is how to tackle the feeders at the end of the AVM surgery, because that will lead you to the residual AVM that will prevent you from having recurrence of the AVM or leaving an AVM behind. So you can see this is an embolized part of the AVM, and I've dissected most of it. And I'm just going to the last part now. Here you can see that this patient had a large clot, and here you can see now I'm removing the clot after dissecting the whole AVM, and you can see that there is some bleeding going on. Now, the most important learning point in AVM surgery is to tackle this bleeding, because this is bleeding from the parenchymal vessels, from the small vessels. At this time, you just cannot coagulate the parenchyma and coagulate the bits of the vessels that are coming in the parenchyma. You have to actually go ahead and trace the vessel, because behind it, there will be a mother vessel that will be feeding this AVM, this coming and bleeding into this AVM. And if you do not tackle this feeder, so you can see now I'm dissecting here, and you can see that there is a bigger vessel that is coming into play here at the back end of the AVM. And this is the vessel that you have to actually tackle, because if you don't leave this, you will have the risk of bleeding at the end of the surgery or in the post-operative period, or you will have a risk of leaving some residual AVM. So this is the most important learning point while performing AVM surgery, that you have to tackle this small vessels by tracing the vessels, going to the main feeder where it is bleeding from, and then coagulating it, as you can see here. And now after this vessel has been coagulated, you can see that I have handled the AVM and the hemostasis is achieved. So this is one of the most important learning points in AVM surgery. And to end my talk, I would like to just show you one small video of a patient that I performed some years back, a couple of years back. And here you see how the planning is important. So this is the initial, this patient actually presented with a bleed to another hospital, and EVD was performed on this patient. At that time, she was unconscious, but after the AVD, she recovered, and then the patient was referred to us. And this was the initial picture of the AVM. So first, to locate where the AVM is. So if you see this MRI image, you can see how close it is to the tectal plate. This is the DSA. You can see the AVM is being fed by both the superior cerebral arteries and draining into the vein of Galen and also into this straight sinus. So what we did is, we thought a lot about what is to be done about this patient, whether any kind of radiosurgery. But considering how close this was to the tectal plate, we decided against performing a radiosurgery. We looked at the anatomical features of this AVM. Then I made this 3D model. Now you see this model. It is divided into 3 phases. The yellow part is the brainstem part. The red part is actually the arterial feeders. And the blue thing is the venous phase. So I studied the 3D model for a long time, and this is how the model looked, and I could actually segregate all the parts to study the anatomy. And then I realized that we could operate this patient, and this is just a short video that I will go through quickly. And this patient was operated in a sitting position with the midline suboccipital approach. So the key steps is to first identify the location. Next, identify the feeders that are coming to the AVM. So here you can see that I've retracted the cerebellum down and I'm opening the arachnoid to identify the feeders on both the sides. So this is the superior cerebellar artery on one side, then going over to the other side. You can see that I will identify the vessel on the other side here. So now on both the sides, I've identified the superior cerebellar arteries that is feeding the AVM nidus. And then we start the dissection. First, just to see the whole AVM nidus, these are some small tweaks that I had to take before I could get the whole nidus into view. And now you can see beautifully how the nidus is being fed by the superior cerebellar arteries on both the sides. This is the ICG view. This is on one side. This is the venous phase. And now you can see that after seeing the ICG, I'm going to start dissecting the AVM. The 4th nerve was actually into play here, and I've actually pushed it down slowly and steadily. You have to go and perform the AVM surgery. You identify the abnormal feeder. You have to be very careful not to take a normal vessel. Identify, coagulate, and cut. So that is what I'm doing. I don't have time to show the entire thing. So here you can see I've pushed the 4th nerve down now, and I'm going into the main feeder. Slowly and steadily approach each one of these feeders and dissect it and separate it from the nidus. As you can see that it was on the AVM surface. So there was no question on the brainstem surface. So there was no question of dissecting the nidus from the brainstem surface. So I had to come circumferentially and reduce the arterial supply into the nidus and reduce it to a small bit and then occlude the nidus on the surface of the AVM, on the surface of the brainstem. So here you can see that the nidus is now decreasing in size slowly. So each and every feeder has to be identified, coagulated, and cut. And this is the last part where you can see this huge vein that is going into the vein of Galen. And now this is the last part of the AVM. You can see how the nidus is actually shrunken in size. This is the last part of the feeders that I'm now getting. The vein is left to the last part, and now this precentral vein is being coagulated, disconnecting it from the surface of the vermis. And that's the last venous vein that is going into the vein of Galen, the whole channel. Some last feeders coming from the vermian region into the nidus are also being coagulated. And you can see that was the last feeder that was coming there and going into the nidus, which I also coagulated. And this is at the end of the surgery. You can see that the whole nidus has been coagulated, and this is the normal venous supply. And this patient did well. And now at a follow-up of 2 years, she's still doing well and is back to her normal activities. So thank you very much for your invitation.
Thank you very much, Abhidha. Any comments from our discussants? Prof. Alexander, would you like to comment?
Professor Shah, thank you very much for excellent talk, excellent cases. I have no comments. I only want to say that individualized approach to the management of AVM is crucial, and it depends not only the recommendation of Martin Spessler or Aruba recommendation. We must rely very much on our own experience, institutional experience, and our possibilities, technical possibilities in management of the AVMs. So that is my comment, and once more, thank you very much for excellent talk.
Thank you, Dr. Alexander.
Prof. Sinha, you'd like to ask?
Abhidha, I like your comment, dialogue, play with DSA, because it is very, very important for AVM to track the vessels. So it solves a lot of problems. And just I want to ask anyone from Dr. Sabino or you have an experience of the AVM with aneurysms association, and what extra prophylaxis we do in these patients?
So I have seen a lot of AVMs with aneurysms. Recently, I've done one which was being fed from the ACA and had a aneurysm very close to the nidus. So in that situation, I dealt with the aneurysm and the nidus. But for an aneurysm that is in the feeding artery, which is away from the nidus, I would just leave the aneurysm and observe it after treating the AVM.
Can I say something? Thank you.
Yeah,
the same, and the flow-related aneurysms are totally different from, the common order intracranial aneurysms. They are very, very frequent. They are a red flag, as I told you, for, rupture. And usually, in most of the cases, they are treatable by means of removing the AVM. I just want to add a comment about the pre-op embolization. I don't want to, that to pass a wrong message in terms of. I totally agree with what Abhidha told, and obviously huge experience of Professor Goel. We selected or we opted some pre-op staged embolization only in a very small subset of AVM, of grade 3 AVM, and grade 3 AVM. Maybe I didn't stress so much this concept. For sure, surgery is beautiful, and microneurosurgery is enough for grade 1, grade 2, and most of grade 3, because, the technique of skeletonization, she showed us, beautiful case about, tactile plane AVM. It is a mastery of surgery. You skeletonize everything, you just recognize bystander. It's a patient surgery. You have to keep very patient to recognize. And this is how to dismantle a bomb, it's the same play, how to dismantle a bomb. But in some, very small, very, very rare cases of grade 3 AVM, where the feeders come from the depth and the arterial, my opinion, as I showed you in our institution experience, it was also, we did different cases with my chief, also with my previous chief, and he has a huge experience in treating this kind of AVM. And we developed this technique reserved to just a small subset of AVM. Because as rightly Abhidha showed to all of us, that small, very small bleeding coming from the deep feeders, especially where they are hidden from the nidus, there is no way to coagulate that with bipolar. And it's mechanical, and you cannot use any hemostatic stuff. They are just bleeding coming from everywhere, and it is diffuse. And also, maybe I missed it to highlight another important concept, the last one, and then I shut up. Especially endovascular, preoperative endovascular embolization of AVM is very useful in case of rachemous nidus. The nidus of AVM can be compact, can be very visible, and as in the most of cases as they show it, but in some cases you see some diffuse nidus, okay? So you don't know where exactly the nidus is because it is not compact. It's very tiny vessels all around. In that case, opting for, that should be grade 3 for sure, as I told you. I'm talking just about some subset of grade 3 AVM. In that cases, the embolization, preoperative embolization can lead to make the nidus more compact, more firm. And this is very good for intraoperative recognition of the boundaries also of the nidus. This is just a matter of strategy. And I like it so much, also the 3D picture reconstruction of the 3D printing of the AVM, because it's very useful to mentally, configure and plan your approach. So for experienced surgeon and for young neurosurgeon also. Thank you so much. Congratulations to all of you once again.
Thank you, Shabino.
Thank you very much.
Thank
Any
you.
other comments? Prof. Enkhbayar, would you like to comment anything?
Thank you very much for your great presentation to show us the surgery of very complicated AVM surgery. And I have one question. How to manage to the blood replenishment during the AVM surgery hemorrhage? Do you use cell saver or fresh blood? Do you understand?
Yeah, I understand. We use fresh blood. We use fresh blood. So we keep a lot for a high flow AVM. We keep a reserve of quite a big units of blood, so that if it does bleed, then we use fresh blood. We do not use replacement. We use fresh blood.
Okay, thank you.
Yeah, is there any more questions? Prof. Kato?
Thank you, Abhidha. A nice video. And I think for the developing countries by ACNS, I think maybe you can show them step by step. So from the planning and also to the surgery or preoperative embolization or radiosurgery. I think our ACNS has such kind of a video or atlas, so video series. So maybe you can send step by step. That is very, very important. Then maybe finally they can do such a difficult cases.
Okay, Professor.
I think elegant lesion and also the large one is maybe most difficult cases so far, I think. But anyway, even a small one, I think you should show them very precise precision.
Okay, I will share the video.
Okay, thanks. Thank you very much.
Thank you very much, Abhidha. Any more questions? If not, we will move on. Prof, what you want to ask? You want to comment anything?
Oh, no, just say thank you and congratulations, Mubarak. Thank you very much for your achievement.
Thank you. Thank you, Professor Pirzad.
Thank you. Thank you very much, Abhi, for, I think, a very concise and a very good summary of how to approach an AVM. I think the conclusion was good, and I think in a way it makes us all sort of say, yeah, look step by step, like how you said, you can move on to Prof. Atul's grading, but you have to be aware of your limitations and I think your capabilities. That's what's important. So before we end our webinar session today, I'd like to call Dr. Mira Nasir from the United Arab Emirates to introduce herself and maybe give us a short presentation of her work and her work as a neurosurgeon in UAE. Mira, are you there?
Hello,
Hi.
good afternoon. My name is Mira Ali. I'm R6 in neurosurgery program in Dubai, out to the Saudi board. Good afternoon, everyone. It's really an honor to be here today among inspiring and leaders discussing women neurosurgery. Neurosurgery program, one of the most demanding specialty in medicine, and it's just not just a career choice. It's endurance, responsibility, and a lifelong commitment. As a woman in this journey, it has been deeply challenging but profoundly meaningful. Choosing neurosurgery was not the easy path. It meant long hours, emotional and physical exhaustion, and constantly proving competence in a field where women are still underrepresented. But it also meant discovering strength I did not know I had. Strength built through discipline, consistency, and showing up every day, even when it was hard. For me, neurosurgery represents more than operation rooms and examination. It represents service, trust, accountability to patients at their most vulnerable moments. It has taught me humanity, resilience, and the importance of mentorship, especially for the young women who are still questioning whether they belong in this field. I believe that women bring invaluable qualities to neurosurgery. They bring empathy without lose of strength, attention to details without fear of indecisiveness, and leadership rooted from responsibility rather than ego. These qualities enhance patients' care and enriches our teams. My goal is not only to grow as a neurosurgeon clinically and academically, but also to be part of a culture that supports, mentor, and uplift women in their specialties. Representation matters not just for recognition, but when young women see someone who looks like them stand here and speak with confidence, it quietly tells them this path is possible. Being a woman in neurosurgery in the UAE comes with its own layers. It's shaped not only by clinical demands, but also by cultural expectations and personal identity. Learning to navigate through these layers has been an important part of my journey in UAE. The future of neurosurgery in the UAE is diverse, capable, and inclusive, and I'm really proud to be part of a generation of women who are not asking for permission to be here, but earning our place through excellence, dedication, and impact. Thank you, everyone.
Thank you very much, Mira. Thank you for joining us. We hope we can get more women from the UAE to come in and maybe present. All right, maybe you can present to us something from your hospital in one of these next webinars. We're really looking forward to that. So
Excuse me.
before I close, any comments from
Yes,
anyone?
excuse me, Dr. Sharon.
Yes.
I would like to introduce a woman neurosurgeon at her Shastan Hospital. Dr. Ayun Tsitsek, are you there?
What is her name, Prof. Enkhbayar?
Ayun Tsitsek Dartsuren. Ayun Tsitsek.
Okay, let me invite her in, yeah. Okay.
Dr. Ayun Tsitsek?
Yeah, she's joined in, yes. She's here. Okay.
Please introduce yourself.
Yeah, I'm here.
Okay, can you introduce yourself?
Hello, everyone. My name is Ayun Tsitsek. I'm happy to introduce my short myself. And sorry, may I? Did you see my presentation?
Yes, yes.
Yeah. Oh, sorry.
Yes, we can see it.
Okay. I'm working at the first central hospital of Mongolia by neurosurgeon. I graduated 2007 to 2013 in Mongolian National University of Medical Science by bachelor degree, and I totally studied in 3 years from general surgery residence to neurosurgery fellow. My work experiences, 2030 to 2050, local doctor, and 2019 to 2025 March and Third Central Hospital, and now I am working at for Central Hospital present. I am member of the Mongolian Association of Mongolian Surgeons and AASPN. 2 years ago, our team attended in the third Congress of AASPN in Japan, Yokohama City, and it is our picture. There are our Mongolian women doctors. It's me and Dr. Dolam and Dr. Hantol and Dr. Vincent with Dr. Marata. our neurological clinical center has 45 beds, general ICU 8 beds, and 13 neurology doctors, 6 neurosurgeons, 3 fellows, and 20 nurses, and 2 operation rooms. Of course, we have a complete team, you see there. And addition, our abroad consulting is USA and Japan. Our collaboration is with the Foundation, Taipei Medical University in South Korea. We did this type neurosurgery, brain and spine in all of ages. This table is our total number of surgery by years. Our neurosurgical section was started in 2020 in Force Central Hospital. Of course, you see our surgery is sharply improving step by step. Thank you for attention. Yeah.
Okay, thank you so much for that very nice and concise presentation, Oyus Zek. Thank you very much. So before I end the session today, is there any comments? If not, I'll ask maybe Professor Kato, would you like to comment anything before we close?
I think maybe Alexander and Singha, any comment?
Yes, I want to compliment this Mongolian society. Even with COVID, the number of cases were rising. I want to compliment this continuous rise of the number of cases, operative cases. Good, it's good progress of the neurosurgery in Mongolia.
Yeah, sorry, but it's just our first central hospital.
Yeah.
Before 2020, first central hospital doesn't have neurosurgery. Just in Mongolia, in third hospital is neurosurgical department.
Good.
And now our neurosurgical section is will branch it.
Good. Keep it up.
Let me add you also a comment, that I saw that in last year you did, more than 700 cases, 775, something similar, and you are only 6 neurosurgeons. So it means that you live there in the OR. And you don't have any private life, maybe, because if you share the number of the surgery by the number of the surgeons, it means that you are really good, and congratulations from the bottom of my heart, because I know very well how difficult it is to, increase the volume and speed up the volume like that way. So congratulations.
Thank you.
Prof. Alexander, you want to comment?
Very briefly, also, I want to wish the best and want to wish to develop and prosper to Mongolian Neurosurgical Service. And international cooperation is a key point in this development. It is growing. So all the best, my colleagues.
Thank you.
Prof. Kato?
Thank you very much, Dr. Oyun.
Thanks so much. So maybe hope maybe the WNS education course maybe can have some chance to visit the Mongolia.
Yeah.
If possible, I think, yes.
Yes, Professor Kato, I hope so.
Yes.
Going on.
Maybe just we can maybe Abhidha Shah, they will contact you soon, I think. Maybe summer is the best time.
Yes, summer is best time in Mongolia.
Okay. So we'll discuss. Thank you very much for a nice
Thank you very
presentation.
much.
Yeah.
So
And please, also Sabino, maybe you can share your surgical skill for the video
you.
for ACNS, please. Thank you so much.
Thank you, Professor. Thank you so much. I'm honored.
Thank you. Thank you.
More than happy.
Just a comment from me. Any fellow from Mongolia wants to come to my center for 2 months, I will give local hospitality to the fellow. Only he has to pay for air travel. But local hospitality from my side. We are most welcome to India for 2 months.
Thank you. Thank you very much, Professor Singh.
Just Enkhbayar, you must write to him as soon as possible, I think.
Yeah.
Okay. Okay. Thank you. Of course.
All of us are totally available. As I told you, we have some facilities in terms of accommodation also. It is not paid position, but I showed you that we have what we call the Erasmus train sheet program. That is especially for accommodation. If you want, you can send me an email and we keep in touch and I will send you a link with all the details.
Okay. Thank you, Dr. Sabino.
Thank you so much. Thank you.
Okay.
We
will
are
in touch you.
Yeah, we are hosting several fellows now from all over the world, from Turkey, from Pakistan, Uzbekistan, from everywhere. So they are coming now. Thank you.
Okay. Thank you.
So I think we come to the end of this webinar. I'd like to thank all our speakers for sharing their expertise. And I think Prof. Enkhbayar has actually today shown us what global neurosurgery is, because I believe that through the years, the development and performance of a country has improved through global neurosurgery and the help from, I think, as she highlighted just now, Prof. Kato and the late Tetsuo Kano. So I think it goes to show us that I think a bit more commitment and sharing actually can go a long way. So I think thank you everyone for joining us today. Hope to see you all again in a month's time. So thank you and have a good Sunday. All right. Good night.